Loretta, you're on mute.
Let's try this again. Hi, can you hear me now? All right. Good afternoon, everyone. I'm Loretta Hoffner, the Executive Director of the Maryland chapter of the American Academy of Pediatrics. We're extremely pleased to have you join us today on the first of our webinar series with Dr. Cliff Mitchell entitled Lead, Asthma, Radon, and Healthy Homes in Maryland, New Resources for Clinician and Patients. This is our first foray into the virtual CME webinar event space, so I welcome you to all of that. And after today's event, all attendees will receive an email from the Maryland Chapter AAP in regards to the process for claiming CME credits. With that, I'm going to turn it over to Cliff Mitchell, who is the Director of Environmental Health Bureau at the Maryland Department of Health. Cliff, it's your meeting.
Thank you very, very much, Loretta. And I really want to give and acknowledge the assistance of both the Maryland chapter of the American Academy of Pediatrics, as well as our hosts for today's meeting, Green and Healthy Homes Initiative, and their Executive Director and CEO, Ruth Ann Norton. This has been obviously a challenging time for everybody. I recognize that it is challenging for all of you who are providing clinical services or other kinds of services to children affected by a host of environmental problems and challenges related to housing. So as we start, I just want to say a few things in introduction, and then we'll go ahead. This is obviously, as I said, a challenging time, but one of the things that the Maryland Department of Health is committed to doing is continuing to focus on not just COVID-19, but all of the issues that are relevant for children's environmental health. We are, among other things, through a cooperative agreement with the CDC for our environmental public health tracking program, providing this CME at no cost to you for actual CE credit. And our goal is to continue doing this in future sessions to focus on children's environmental health issues in ways that are meaningful, productive, relevant, and useful for you as you work with children across the state of Maryland to improve their health. So with that, I'll go ahead and get started. Let me just first start with the objectives for this program. At the conclusion of this presentation, we anticipate that you will be able to identify the changes in Maryland laws and regulations that reduce the blood lead level in a child that will trigger a response from state agencies. And we will talk about who those state agencies are and what those responses are. We want to make sure that you understand recent trends in the state for blood lead levels and blood lead testing rates, because it is very much part of our goal to improve blood testing rates as part of this program. We want to identify and access services, and we want you to be able to access those new services for home-based pediatric environmental health hazards, including lead, asthma, and radon, all of which are now provided through the Department of Health, the Department of Environment, the Department of Housing and Community Development, Maryland Medicaid, and the Children's Health Insurance Program. And these services are available to you as clinicians and as others to help children who need services related to home-based environmental health hazards. Okay, so just to sort of give you an overall sense of the format, we are going to be talking with you today twice, today now and at 5 p.m. We will also be talking with you about the subjects that I mentioned. Our second session in March will be an overview of healthy homes and the approach to children's health. And there we will talk more generally about the epidemiology of children's health and healthy homes and environmental health hazards. We'll talk specifically about lead, asthma, radon, and injury, pediatric injuries, as they relate to the home and home environment. And in addition to providing an overview of new state laws, regulations, we'll also talk about some of the additional resources that are available to you. And then the third day will be a case presentation where we focus more specifically on how, as clinicians, you might interact with local health departments, the Department of Health and the Department of Environment, and work with your patients to access these services. I have no conflicts to disclose, so let's move into the presentation. So first of all, what has happened to lead poisoning? And I want to emphasize that lead continues to be a challenge here in the state. And this is a chart that's been prepared on an annual basis by the Maryland Department of Environment. This is a chart that actually shows you how lead and lead testing has progressed. And so if you just look at the chart here, what you'll see, in the early 1990s, we were testing a large number of children, 60,000, but a significant percentage of those children had elevated blood lead levels. In fact, in 1993, as you'll see, almost 15,000 children had a blood lead level annually. These are incident cases of 10 micrograms per deciliter or greater. And it was not uncommon at that time to see children with elevated blood leads in the 60s, 70s, 80s, 90s, and hundreds. As you probably know, the Kennedy Krieger Institute, Mount Washington Pediatric Hospital, other hospitals would frequently have inpatient children who were getting chelation intravenously. And we had children die of acute lead poisoning. Over time, thanks to the intervention and legal interventions pioneered here in Maryland and elsewhere, we were able, and the state has been able, to consistently through the early 2000s drop the number of children with elevated blood lead levels, so that if you look in the most recent year for which data are available, we've moved from having a quarter of the children tested, 23.9% here in 1993, to only 0.2% of children tested in the state with a blood lead level of 10 micrograms per deciliter or greater. This has been a dramatic public health success story. And I don't mean to in any way to diminish the story by saying we're not done yet, and there are still children who in fact continue to be poisoned by lead on an annual basis. But it is important to acknowledge that thanks to the work of the Maryland Department of the Environment, the Department of Housing and Community Development, local health departments across the state, and notably Baltimore City Health Department, Prince George's County Health Department, and others, it has been absolutely a success story that we have moved from such a dramatic impact to a situation where we're essentially now looking at much, much lower blood lead levels and a smaller number of children affected. But it is important to note that these children are still affected by lead. All right, and we're going to talk about that in the slides to come. So now, Candace, if you'd be willing to drop the first poll onto people's screens, I think we have a poll here for the audience. So go ahead and click on this. Which children are the only children who need to be tested for lead in Maryland at 12 and 24 months? And so go ahead and click on this, give your answers. And so this is, as you'll see, we'll give people a couple of moments to click on this, and I am very, very happy with these results. As you will see, although it is true that children on Medicaid do all need to be tested for lead at 12 and 24 months, in Maryland, as we will discuss, as of March of 2016, all children ages 12 and 24 months, no matter where they live, do need to be tested if they were born on or after January 1st, 2015, up to the age of 72 months. And so thank you very much. I'm going to end the poll now. That's great. And okay. All right. And let me go to the next slide. So if you look now at what's happened with testing in more detail over the last 10 years, this is the picture of more recent blood lead tests, and I want to point out a couple of things about these data. So first, as you will see, starting in about 10 years ago, we really started to level off in terms of the number of children with elevated blood leads. And despite the fact that we've seen more testing in the last 4 or 5 years, and I'll talk about why that is in a minute, we've really seen sort of a leveling off of these, and we're going to talk about the reasons why that might be. So these blue bars represent the number of children tested. The red line indicates the number of children with an elevated blood lead level. And as you can see, despite the fact that we've been testing more, we have not really identified more children. And one of the things that's important about that is that fact suggests that clinicians are doing a very good job of identifying children with acute lead poisoning, because despite the fact that we are testing a larger number of children in the past 4 to 5 years, we're not seeing a dramatic increase in the number of children with acute lead poisoning or lead poisoning above 10 micrograms per deciliter. And just in terms of who we are identifying, in 2019, we identified 257 new cases of children with an elevated blood lead of greater than of 10 micrograms or greater. But we also had almost 900 new cases with blood leads of 5 to 9 micrograms per deciliter. So how do we fare in regards to the rest of the country? Well, it's very difficult to answer that question. And the reason it's very difficult to answer that question is not all states have routine testing for blood lead. If you look across the country, there are a significant number of states, including many of the states that historically are newer additions to the United States, whose housing tends to be a lot newer than some of the older states, and where the public health infrastructure, frankly, may not be quite as robust with respect to children's environmental health issues, particularly with respect to lead, given other pediatric environmental health issues that exist in those states. But if you do look at where we rank, what we can say, and there's one other caveat here, which is if you look at the testing frameworks across the country, many states use still a targeted testing approach rather than a universal testing approach. So whereas Maryland, Rhode Island, Massachusetts, and several other states test a significant fraction of their children under the age of 6 years, in many parts of the country, many states have adopted a framework which is more selective, where they tend to focus on targeting populations that are living in older housing, with a higher risk of lead paint exposure, as well as all children in Medicaid who are required to be tested for lead. But as you'll see from the data here, nationally, for those states that reported blood lead levels to the CDC, 18.7% of those children under the age of 6 years, 72 months, were tested for blood lead. And 3% of those had a blood lead level of 5 micrograms per deciliter or greater. For Maryland, by contrast, we are testing a larger percentage of our population, and at the same time, we are seeing a lower percentage of Maryland children with a blood lead level of 5 micrograms per deciliter or greater. I think that illustrates some of the challenge of looking at these data, which is that it's difficult to compare sometimes states directly, because those states with a higher percentage of children with elevated blood leads are using a targeted testing framework rather than universal testing. So thanks to Dr. Paul Rogers, a recently retired member of the Academy of Pediatrics, for this slide, which is a reminder of why we care about lead to begin with. It is the most common environmental toxin that many children are exposed to in many cases. It's the one that certainly causes a significant still amount of morbidity, although mortality, fortunately, has been drastically reduced in the United States. And I would mention parenthetically, this is not a problem just in the United States. This is a worldwide problem. One of the things that we are seeing is that children who immigrate or emigrate to the United States are often identified because their first blood lead test that they ever have is here in the United States. It is a recommendation to test children under the age of 16 if they are recent immigrants, particularly if they come from countries or grew up in areas where they may have been exposed to lead. They may have lived in crowded conditions, and so they, and particularly if they grew up in urban areas or in other areas where they might have had lead exposure, it is a recommendation. And as they come through global immigration, they often will get their first blood lead test and be found to have an elevated blood lead level. So as Dr. Rogers notes, lead paint in Maryland and elsewhere is still the predominant cause of lead exposure, but we will talk about some of the other sources that are emerging. The average 4-month-old does a lot of hand-to-mouth activity. And also recall that neurologic development in the first years of life, which is absolutely critical, can be significantly affected by exposure to lead, which as a divalent cation looks like calcium, looks like iron, and can be found to interrupt those biological processes that depend on calcium and iron, including very, very significantly the nervous system, the hematopoietic system, so blood forming as well as neurologic development is potentially quite affected by lead. And at very low levels of lead exposure, even 5 micrograms and below, you can see chronic irreversible neurologic damage, which can cause a number of problems, including slowed growth and development, learning and behavior problems, and hearing and speech problems. I mentioned just a moment ago that the picture of lead is changing in the United States. And these are some data that were developed by Maryland Department of the Environment, Maryland Department of Health. And to point out here, if you look at areas that were considered to be at risk in the 2004 Maryland Lead Targeting Plan, in green here, these are areas with older housing that pre-1950 and pre-1978 housing. And as you can see, in those areas, lead paint is by far the predominant cause of identified in children with elevated blood lead levels. Lead paint here, and then lead dust as well. And these two sources considered together probably account for, in areas considered to be at risk, probably up to 90% of the cause of lead intoxication in children living in those areas that were identified. And so urban areas, Baltimore City, large parts of Baltimore County, Prince George's County, and other older areas, including Cumberland, Frederick, and so forth. But if you look at areas where they were mostly not considered to be at risk, and these would be areas in much of the, some of the I-95 corridor, including parts, the newer parts of Montgomery County, stretching up into the northeast of Maryland, Cecil and Harford counties, as well as other areas, some of the rural areas. Look at how the fraction of lead paint and lead dust, which is mainly related to lead paint, is a much, much smaller fraction of the causes of lead paint intoxication. In this case, you can see this, some of the most significant contributors are spices, cosmetics, recent immigration to the United States, travel, and then occupation, parental occupation, and jewelry. These form a much more significant fraction of the causes of lead intoxication in areas that are not traditionally thought of as so much of the at-risk older housing, pre-1950, pre-1978 housing. So at this point, let's do our second poll. Candace? And while Candace is dropping this in, so go ahead and check on this. What's a notice of defect? And I anticipate that this will provide some interesting responses. And our early adopters, and I think that so far relatively few people are the blue line has disappeared on my bottom, so I'm not sure where that, okay, we're looking at it. I'm gonna give people a couple more minutes. We've got almost everybody in, 42 are in, 72% are voted, and I'm waiting to see whether we get a few more responses. Got 43, waiting to click in until the last possible moment. I will say that I am sometimes one of those people who waits to see, and we always do a little bit of a little bit of a regression to the mean here, but I'm going to give people one more minute to click in. And that's great. All right, so I'm just going to stop the polling now. If you haven't gotten your answers in now, 3, 2, 1. Okay, so so this is great. 3/4 of you recognized that the notice of defect is a notice from a renter to a landlord that identifies a potential lead hazard that must be investigated by the landlord. I'm assuming that all of the people in the local health departments in our home visiting program got that one right. But it is not, interestingly, a court order. It's actually a notice from the renter. So we'll talk about this in just a minute. And it is not a laboratory designation for an improperly submitted lead test. So I'll stop sharing the results. I'll close that. And so now let's talk about what's happening with laws in Maryland. And the first one I just want to point out is the law for testing of lead in drinking water in schools. The reason that I'm pointing this out is because we have not done a huge amount of work on water as a source, but because of Flint, Michigan, and because of what's happened, many states, including Maryland, have enacted laws that now require testing of drinking water for lead in all public and non-public schools. So if you look at how that testing started in 2018, it's run by the Maryland Department of the Environment. Specimens are submitted to the Maryland Department of Environment, and in fact, they will be available for public display probably later this year on the Maryland Department of Health website, our environmental public health tracking website. So testing started in the most vulnerable older schools with younger populations and has moved on to involve other schools as well. But 4% of the samples exceeded the EPA action level of 20 parts per billion. Of that, however, less than 2% was from drinking water outlets. The rest was primarily from either taps that are not used for consumption or where we couldn't determine where they were. And as I said, we will be displaying these data later on this year as part of the Department of Health redesign of the public health tracking portal. So if you look at what's happened with new laws, the next law to talk about is the Maryland Healthy Children Act of 2019. Chapter 341 of the Acts of 2019 requires Maryland Department of the Environment or a local health department to notify the parent or guardian and the property owner of the results of the blood test if a person at risk has an elevated blood lead level, which is now, as of last year, we have redefined an elevated blood lead level as 5 micrograms per deciliter or more. It's no longer 10. And so one of the important things to remember is, remember I said that we've got about 250 kids a year with blood lead levels of 10 or greater, but almost more than 4 times that many have blood lead levels of 5 to 9 micrograms per deciliter. So the number of children who are subject now to notification is much larger than it was. The Department of the Environment has subsequently adopted new regulations. We'll talk about those in a minute. But the Act modifies provisions and actually has different requirements for affected properties, and I'll talk about what that means in a minute, in order to satisfy what's called the Modified Risk Reduction Standard. So let me just talk a little bit about how this works in practice. So if we have a child who has been tested and is identified to have a blood lead level of 5 to 9, say 7 micrograms per deciliter, let's first talk about what happens if that test is a capillary test. That is to say, it's used point of care. So if it's a capillary test, remember that this has to be a confirmed blood lead level. So what has to happen is, first of all, confirmation using a venous test in order to confirm that the child needs to be retested with a venous test in order to confirm that capillary, because capillary tests are more prone to falsely elevated positives due to surface skin contamination. Thus, the importance of always carefully prepping the finger or the heel in advance of taking the capillary sample. So what happens is an environmental investigation will occur when MDE's Childhood Lead Registry, and here I want to give a shout out to, if I may, Dr. Ezatola Kavon, who for many years has been the Maryland Childhood Lead Registry. And if I may take a parenthetical moment to tell you all that Dr. Kavon and the people who work in the lead registries across the country are, for the most part, unsung heroes of the improvement in blood leads across the country. They are often not recognized for their contributions, but there are very few people in the state of Maryland who have done as much for children's environmental health related to lead as Dr. Kavon. So if I may take that personal moment. When the Childhood Lead Registry receives a blood lead test indicating the child under age 6 or a pregnant woman has a blood lead level greater than or equal to 5, then what happens is that the owner of an affected property, which is a pre-1978, so it's built 1977 or earlier, has to satisfy what's called a modified risk reduction standard within 30 days after the owner receives that written notice that a person at risk, which is to say a child or a pregnant woman, has had a blood lead level of 5 micrograms per deciliter. And importantly, the investigation has to conclude that there is a defect at the affected property. Now, remember I said in areas with newer housing, in many cases, the cause of the elevated blood lead may be determined, and this is true everywhere. When the environmental investigator goes in, the environmental investigator is looking for what caused the elevated blood lead. They will look for lead paint, no matter where they are, whether it's a pre-1978 housing or not. They will look for sources of lead paint. This is very important, using a device called X-ray fluorescence. They will do dust testing, But they will look in all cases for what are all the potential sources of lead in that property that exposed that child or that pregnant woman. Oftentimes, if it's lead paint, they will identify that readily, and that will lead to a conclusion that there is a defect meaning that there is lead paint present. It could be lead paint from the original apartment, but we have seen cases, or MDE has seen cases, where that lead paint, for example, may be related to furniture that's been brought in to their property that has been stripped by the owner and it was covered with lead paint. It may be related to other factors, however. So it could be related to spices. It could be related to toys. The investigators will always look for all those potential causes until they can identify what the cause is. In many cases, they may not, especially with people who have lower lead levels. It's possible that they will not be able to identify a single source. But if they identify that there's a defect, which is to say lead paint at the affected property or something else that can be remediated, it is up to the owner to fix that problem and then document that the lead has been fixed. In many cases, if it's a child who is, for example, emigrated from a different country, it may be that the source was the original exposure in that country, in which case there is no requirement to do the modified risk reduction standard because the child was lead poisoned elsewhere. So that's what is done with the investigation, but the investigation has to determine that first. Now, as clinicians, let me just talk with you now all about case management guidelines. Very shortly, you will be receiving electronically from us our new 2020 Maryland guidelines for the assessment and management of childhood lead exposure. These have been updated from our previous case management guidelines, which were last distributed in 2016. And again, I want to give my thanks to the Green and Healthy Homes Initiative, Maryland Department of the Environment, for all of their cooperation and assistance in putting these together. These are actually available for download as we speak and on the websites of both Maryland Department of Health on our lead page and at the MDE website as well on their lead poisoning prevention pages. And there are some new things to point out here. First, these have been updated with case closure guidance. I'll go through that in a minute. And we've updated our resource lists with clinical resources and other resources that you may find helpful as you work with your children. So, as I mentioned, this now reinforces the idea that all children must be tested at 12 and 24 months if they were born on or after January 1st, 2015 and are under the age of 6. And this color-coded table takes you through the resources for what to do if you find children with a capillary blood or a confirmed venous blood. And we continue to show you the lead risk assessment questionnaire that's also been updated so that you can ask about some of the most important and significant causes of lead exposure. So for children, as I mentioned previously, who have a capillary blood, it's important to confirm that with a venous test, and the time interval between your capillary test and your venous test confirmation is determined by what the result of the capillary test was. So with capillary tests that's showing a lead level of 60 to 69 micrograms per deciliter, that should be confirmed by a venous test within 24 hours. If the test is 5 to 9, it can be within 12 weeks, although certainly there's no harm and no foul if you confirm sooner than that, and many clinicians do in fact do that. Secondly, we've updated our initial management recommendations. This is the abbreviated clinical guidance for the blood lead level of less than 5, 5 to 9, and then 10 or above. And this is the table for blood lead levels now of 5 micrograms per deciliter or greater. We've also updated our clinical guidance for elevated blood lead levels overall, including things like getting a medical and nutritional history, doing follow-up blood lead monitoring, and home environmental investigations, showing you what should be happening with your children as you manage them. This is what the expectation is that will be taking place in those families. So what do you do as a clinician when you have a child with a blood lead level of 5 micrograms per deciliter or greater? First and most important, identify the source of exposure and stop it. And that often requires consultation with a local health department, with the Maryland Department of the Environment. The MDE will, since the Childhood Lead Registry is located within Maryland Department of the Environment, oftentimes you will hear from them before even you receive your own results from the lab, because lab results go directly to MDE on a daily basis from national testing laboratories. But obviously, if you have a point of care testing, you'll know the answer or the level beforehand, and we'll decide how to contact and whom to contact. So if it is possible to identify a point source like lead paint, the important thing is there are approved professionals who have been trained and certified both to investigate and to fix lead paint problems. And it is very important to make sure that you are working with licensed professionals. They are licensed by the Department of the Environment as lead risk assessors, and they are trained by the Department of the Environment in what's called RRP, or Renovation, Repair, and Painting, to abate lead hazards according to strict EPA standards and HUD guidelines that require protection of the individuals. In many cases, if these are rental properties that are covered under Maryland law, pre-1978 rental properties, the notice of defect provided by the renter, or with the assistance of the renter, to the owner of the property, sets in motion both legal protections for the renter and an obligation on the part of that property owner to investigate and, if necessary, fix that problem. Maryland Department of the Environment and others including people who work in non-governmental organizations that work with housing a lot, such as GHHI, can assist you in and your patients in how to use the notice of defect and how to address these challenging situations. So, and if the source is not lead paint, but something else, it is very important to ask about those, identify them, and remove them. I do want to talk for a moment about case closures. We recommend to the local health departments that, that children have at least 2 blood lead levels of below 5 micrograms per deciliter before closing those cases out. Because as you know, if they have long-term deposition of lead in the bones, their blood leads can oscillate. They can go up and down. So it is important to confirm with at least 2 blood lead levels at a 3-month interval, so that you can be confident that these are actual, that they have actually gotten rid of the blood lead. And there are cases with children who, in fact, have deposited blood lead sufficient that you can't actually clear them, and that they should be aware of the fact that they have elevated blood lead that may last for quite some time. So let me finally talk about some new resources. So these include 2 important programs that were approved by the Center for Medicaid and Medicare Services in 2017 and are now available to you through local health departments and through the Department of Housing and Community Development, both funded under the Maryland Children Health Insurance Program. These 2 programs include Healthy Homes for Healthy Kids, which is a lead abatement program in which your families who are residing in homes where the child who is lead poisoned lives for at least, or stays at least 10 hours a week, where that property can be abated if it meets the criteria. It doesn't apply to commercial buildings like large rental buildings or apartment buildings, but it does apply to owner-occupied homes as well as to other properties, including small rental properties if they are individually owned by a person rather than by a corporation. The second program is a home visiting program in which our local health departments, many of whom are on this call, go out and will do home visiting for children with lead poisoning and or moderate to severe asthma. So the first program, administered through the Department of Health and then also through the Department of Housing and Community Development, is a way for your patients who have properties where they may have lead, but they don't have the financial resources to fix the lead problem, which is a very common situation. In that case, using a variety of tools available to them, the Department of Health, Department of Housing and Community Development, and MDE have partnered with the state and through the Children's Health Insurance Program to provide funding, as well as other potential sources of funding, to help these families abate the lead program. And it is important to be able to refer children. Here's the number that you can call, 866-703-3266. And there's an email which we'll also show you. And you should feel free to refer your children, your patients or clients with problems to those resources where we will work, and we will work with them to see if they are eligible for these services. Our second program, our home visiting program, which is available currently in 9 jurisdictions across the state, shown here in this map, is for children. Again, the eligibility is they must be, just as in the previous lead funding program, they must be under the age of 19, enrolled in or eligible for, and this is very important to understand, they don't have to be currently enrolled, but by financial resources, if their limited financial resources would qualify them for Medicaid or the Children's Health Insurance Program, they have to live in one of these 9 jurisdictions and have a diagnosis of moderate to severe asthma and or a blood lead level of 5 micrograms per deciliter or greater. A second resource, or a third resource I should mention to you, is that Immunet now is providing alternatives to the blood lead testing certificate. So as a parent, if your parents are required to get a blood lead testing certificate, you can now go into Immunet, pull up their child's record. There's a tab here for lead test results, and you can provide that in lieu of the lead testing certificate, making it much easier on you and them. And so finally, let me just talk a little bit about what we're doing to increase testing frequencies, within the state, because I mentioned that we are still not testing every child here in the state. And the requirement now, as of March 2016, is that all children who are born on or after January 1st, 2015 must be tested at ages 12 and 24 months. Before that time, obviously, most of those have aged out now, so this is not so relevant anymore. But we have gone through the transition period where older children only had to be tested if they lived in the areas identified by the 2004 targeting plan. The other thing we did is increase access to point-of-care testing, and as you'll see in the next slide, overall, if you look at the children in a cohort that we are testing at ages 1 and 2, we're still, as of 2016 and 2017, only testing for the most part on a statewide average about half of the children in that age cohort. This is where point-of-care testing regulations started in 2015, making it easier to do point-of-care testing, which has helped tremendously. The other is now, as of March, I mentioned this of 2016, this is where our testing of all children in the state happened. And so you can see that for our ages 1 and 2-year-olds, we did see a significant increase, both from the increase in point-of-care testing and from the change in testing requirements. But this has still resulted in probably about a 10 or 15% bump. We're still a long way from testing all children. And so our revised, I will add one other thing, which is MDE in its revised regulations from last year also is asking for additional information on the blood lead test requisition. I would implore those of you, I would ask fervently for those of you who are in fact filling out lead test requisitions, please add things like the country of birth and ethnicity and the medical assistance identification number, as well as your NPI. These are the additional things. All of these help us to more quickly identify the child accurately and get those ancillary services to that child. We're doing more outreach, and as I said, you will be receiving a clinician letter before long with our updated guidance, as well as the original reference to our blood lead testing resources on our website and the MDE website. And so the takeaway message, I think, for you, before I do that, let me ask for the last poll. Candace, what's our last poll? So, what is who is eligible for Maryland's? So this is a little trickier. And let me just emphasize, all right, about half of you have responded. I'm going to give people 30 more seconds. or maybe not. Maybe I'll just end it now at a minute. All right. So as you can see, the correct answer was none of the above, because remember, you don't have to be under 6, you have to be under the age of 19 to be eligible for these services. You don't have to be enrolled in the Maryland Children's Health Insurance Program, you just have to be eligible for the program. And you have to have a blood lead level of 5 micrograms per deciliter or greater, not 10. So the correct answer was D, none of the above. And that's just to reinforce, you should absolutely feel free to contact us if you think you have a child who is eligible. So takeaways for the clinicians, they've been doing, I mean, all the clinicians have been, I think, doing an excellent job of identifying lead poisoned children, but we now have more opportunities to address multiple lead sources with lower lead levels. We have expanded resources across the state through MDE, MDH, the Department of Housing and Community Development, to help patients and you as clinicians to address these problems. And just make sure that when you test for lead, make sure you include the Medicaid ID and other data to facilitate following up. So at this point, I'm going to stop and open it up for a couple of questions, and then we'll be done. So if you want to put questions in the chat, I can't see the chat, but I think Chevelle and Candace can see the chat, and we'll see whether there are any questions. And if you want to unmute, you may certainly unmute. All right. Are there any questions in the chat, Chevelle or Candace?
There was one question that was from earlier stating, is there data for percentage of tested children in Maryland on Medicaid? I have found that this to be a better comparative metric.
Oh, that's a very good question. I didn't present those data here, but Medicaid does routinely look at, it is one of the criteria for managed care organizations. And so they do look annually at the percentage of children who are in fact tested because it is a requirement for participation in what's called EPSDT, early prevention, screening, diagnosis, and treatment. So yes, that is reported on a regular basis. I did not report it in these results. Any other questions? If not, I've given you the resources, and I will conclude by thanking our sponsors and co-sponsors, the Maryland chapter of the American Academy of Pediatrics, Dr. Paul Rogers, Green and Healthy Homes Initiative, and the MDE Childhood Lead Poisoning Prevention Program, as well as CDC, for its financial support of this CME event. And with that, I will bid you all a very pleasant afternoon.
Great presentation, Dr. Mitchell. Thank you very much.
We'll see you at 5.
I just stopped the recording.